The subcommittee will come to order. Today, the Readiness Subcommittee and the Personnel Committee will meet in a joint session to receive a briefing on how the Department is managing their medical military construction program. As our nation responds to different threats, we adapt and change our strategy, and the force structure of our military. And one of the most recent decisions to change our force structure has been to expand the Army and Marine Corps and add 74,000 soldiers and 27,000 Marines. The services have been steadily applying facility funds to accommodate this growth, but some areas are significantly lacking, including medical facilities to support the growing force. It is imperative that the men and women that join our armed forces are provided the best medical care possible. To this end, I am glad that we provided almost $1.3 billion to support medical facilities deficiencies in the stimulus bill. I hope that the witnesses will take the opportunity to address the Department's investment priorities on how they are managing to address medical facility needs for all of our growing installations. On a related point, our subcommittees had the opportunity to visit Bethesda yesterday, and we were amazed at the resilience of the wounded warriors, their high spirits, their bravery, the dedication to our country. And to receive men and women at Bethesda was within 48 hours of a casualty from anywhere in the world is an amazing feat. That was very, very impressive to know that. This capability that exists today will particularly challenge when the Walter Reed complex is realigned to Bethesda and Fort Belvoir. We were briefed that the majority of care will be moved from Walter Reed campus in August of 2011. With the construction of almost $2 billion in the National Capital Region, in addition to commissioning the facilities and installing complex equipment, there's no question that this would be a very difficult task. A smooth, seamless transition from Walter Reed to Bethesda and Fort Belvoir is essential to provide the quality of care for our wounded warriors. The chair now recognizes the distinguished chairwoman from California, Ms. Davis, for any remarks that she would like to make. Ms. Davis.
Thank you. Thank you, Chairman Ortiz, Mr. Forbes, and Mr. Wilson for this joint hearing of the Readiness and Military Personnel Subcommittees. The Military Personnel Subcommittee is tasked with oversight of the Defense Health Program, and the Readiness Subcommittee with the oversight of military construction. While our staffs have already spent lots of quality time together on this topic, it's good that we are meeting jointly to receive testimony and explore the issue of medical military construction. As Chairman Ortiz mentioned, it is vital that we program and build the infrastructure required to support the expansion of the Army and the Marine Corps. It is our responsibility to ensure that our service members and their families, specifically their families too, have the facilities they need from the outset and not be forced to wait years before these facilities are even programmed, let alone built. We must also ensure that the recommendations of the Based Realignment and Closure Commission are implemented. Yet another reason to have this hearing is the fact that medical military construction is handled differently by the Department of Defense than all other MILCOM. That is not to say that it is bad different or good different, just different. Consequently, it is both appropriate and a responsible oversight for our two subcommittees to examine this process so that we may understand exactly how the department analyzes, prioritizes, budgets, and then builds medical facilities. We must also keep in mind the long-term, enduring costs of maintaining these facilities once they are completed. Today, we will hear from all of the relevant parties within the Department of Defense. Dr. Ward Casscells, the Assistant Secretary of Defense for Health Affairs, will describe how Health Affairs TRICARE management activity prioritizes projects. Mr. Peter Potochney, Director of Basing for the Office of the Deputy Undersecretary of Defense for Installations and Environment, will speak to BRAC issues. Finally, and importantly, we will hear from the Service Surgeons General, Lieutenant General Roudebush from the Air Force and Vice Admiral Robinson from the Navy, and Lieutenant General Schoomaker from the Army, of how well the current process supports their requirements. Welcome to all of you, and thank you very much for being with us. Throughout our conversations today, it should go without saying that all of us, both members of the legislative and executive branches, are committed to providing the very best care possible to service members, their families, and our retirees. Chairman Ortiz rightly mentioned the impressive feats that our military health system has made routine. On Monday, many of us had a chance to meet and speak with a wounded warrior at Bethesda. Given how recently he was wounded and the type and extent of his injuries, it was awe-inspiring to see how far he has come so quickly. All of his caregivers agreed that just a few years ago, any recovery, let alone one as dramatic as his, would have been all but impossible. That the standard of care has risen to such a high is a testament to the commitment displayed on a daily basis by everyone who is associated with the military health system. We must all do our part to make sure this trend continues. Thank you, Mr. Ortiz, and look forward to the hearing.
The chair now recognizes the distinguished gentleman from South Carolina, Mr. Wilson.
Thank you, Chairman Ortiz. And it's an honor for me to be here today with Chairwoman Davis. I appreciate joining our good friends on the Readiness Subcommittee led by Chairman Solomon Ortiz and Ranking Member Randy Forbes for our hearing on military medical construction. I welcome the distinguished members of our witness panel. At this time, Congressman Forbes is actually in a markup of the Judiciary Committee, and I would like to move for unanimous consent to submit his opening statement for the record.
So ordered.
I believe that there is nothing more important than providing the outstanding members of our military, their families, and our retirees with world-class health care delivered in world-class medical facilities. There is no question in my mind that they deserve nothing less. As the grateful father of 4 sons in the military today, our family has experienced the quality service with 2 grandsons born at Bethesda National Naval Medical Center and a granddaughter born at Portsmouth Naval Hospital. With that being said, I understand that there are a number of military treatment facilities that are 30 or more years old. In the district I represent in South Carolina, Moncrief Army Community Hospital at Fort Jackson was built in 1972, and the Navy Hospital at Beaufort was built in 1947. I know that the outstanding medical personnel in each of these facilities provide excellent care to our troops and their family. On personal tours of each facility, I have been very impressed by the dedicated and competent professional personnel I have met. I also know that as a medical facility gets older, it is more challenging to keep up with the advances in medicine. As I prepared for the hearing today, I was reminded that the planning process for military medical construction is very different than that for other types of construction within the Department of Defense. I'm interested to hear from our panel why medical construction is unique within the department. To that end, today I hope to hear from our witnesses how the department and the military services plan to spend medical construction dollars to either replace or modernize our military hospitals. The members of our armed forces deserve the best. With that, I would like to thank our witnesses for participating in the hearing today. I look forward to your testimony.
You know, today we are very honored to have with us 5 distinguished witnesses representing the Department of Defense, and we have the Honorable Ward Casscells, the Assistant Secretary of Defense for Health Affairs, Mr. Pete Potochney, Office of the Undersecretary of Defense for Installations and Environment, Lieutenant General Eric Schoomaker, the Surgeon General of the Army, and Vice Admiral Adam Robinson, Surgeon General of the Navy, and Lieutenant General James Roudebush, Surgeon General of the Air Force. And without any objection, all of your testimony will be put on the record. Mr. Casscells, whenever you're ready, you can begin your testimony, sir.
Thank you, Chairman Ortiz, Chairwoman Davis, Ranking Member Wilson. I'm delighted to be here with my colleagues, and I cannot tell you how much we appreciate your interest in our facilities and your recent visit to Walter Reed. Joining me here today from left to right, I think you've already mentioned General Schoomaker, General Roudebush, Mr. Pete Potochney, who's representing Wayne Arney, the Director of Installations and Environment, and Vice Admiral Robinson. Secretary Gates has said over and over again that our service members and their families deserve the best medical facilities possible. We certainly agree with him, and we appreciate very much the fact that the Congress has taken that to heart. Let me be frank. We do not have big corporations and others for whom this is a top priority calling you. This is the group that advocates for military medical facilities, and we are very grateful that you have taken it to heart. We're in a bit of an awkward position today because the President's budget won't come to you until April. In fact, we don't have the details ourselves. We know what we've requested, and this is being arm wrestled with OMB and the comptroller and so forth now. So we don't know. We won't be able to answer some of your questions the way we'd like to. Likewise, the details of the stimulus proposal and our military medical construction proposals as part of that bill are not yet approved. I can tell you that we have requested a balanced construction program favoring the urgent, the strategic, and the joint. We also are a little bit handicapped today in the sense that we don't have the report from the independent review of the hospital design. This group is due to report now to the Defense Health Board, and we should have that report also in a matter of weeks. Together, these have put us in a position of delay, as your staffs know well. The report that was due in January was only delivered to you, I understand, on your way out to Walter Reed. And I apologize for that. We had hoped you would have several days to digest that. And we will have a full report of all of this in early summer. Mr. Chairman, you alluded to the fact that we have a different funding mechanism, as did Mr. Wilson. We do indeed, and as opposed to regular military construction, which is done by a top-line allocation to the services, the medical construction is done differently, as recommended by, or as required by Congress, and as we, the surgeons and I, and installations and environment leaders, as we have jointly designed. And the way this works has been different from other military construction since the Defense Health Program was created by Congress several decades ago. And what it means is that instead of having the service surgeons general having to ask the line leaders for their budget, Congress set this up so that there would be a Defense Health Program so that the budgets could be put together jointly, and we wouldn't be trading hospitals versus weapon systems. I think the wisdom of Congress's decision there is apparent because we are now once again building hospitals, and I think that's good. There was a time when we were letting the hospitals hospital maintenance be deferred year by year by year. I think the members of these committees are well aware that our accreditation has been, our hospitals pass their inspections, but not with commendation typically. Usually we are cited for deferred maintenance, and we take the pledge to get to it. But you cannot defer these things indefinitely. Otherwise, you may compromise medical care eventually. We are not doing that at this time, but we cannot defer the upgrades of these hospitals forever. As you mentioned, sir, some of these hospitals were built before any of us were even in medical school. So that's 35 years ago. So they can't be neglected indefinitely. The mechanism that we use now to determine these allocations, the priorities, are set by something called the Capital Investment Decision Model, or CITM. This is something that we and our predecessors actually developed. It's been a painstaking business model that has been developed, and we took our cues from the business community and particularly from the Veterans Administration, which, as you know, has revitalized their facilities over the past couple of decades, and they have some really first-class hospitals now. One of the things that's come out of that is commercially available software that facilitates this decision-making. So this is what we've used. We've worked on it together, and I hope that what we will be able to do today, if not answer every single question about a given facility, is at least persuade you that we are working on it in a transparent and in a earnest and joint fashion. It remains to be seen whether this new process, CITM, will actually be the right one, or whether it's just another layer of DoD bureaucracy laid over top of service bureaucracies. None of us wants that. What we want, of course, is to have an even playing field and to have people speak and meet together, share their best ideas, cross-fertilize, and reach a consensus on what the military hospitals should look like. And I believe we have. We want hospitals that will be welcoming, that will be empowering for the patients, that will be comforting. They will be a little bit different than the civilian hospitals. We compare ourselves constantly to what's happening at the Mayo Clinic or the Cleveland Clinic or Kaiser Permanente. Our needs are a little bit different because we have such a preponderance of psychological issues to deal with. But many of the features are ones that we have been able to take from the VA and from the commercial competitors. And I say competitors in a respectful way, but you know, we are the only HMO that deploys. I'm sure you've heard that expression. And it's critical that the military treatment facilities be maintained strong and, in fact, be strengthened. The future of the military health system requires this. We cannot outsource everything. There are things we can do in that vein, and I want to commend what the Air Force has done with great wisdom and great innovation, working with the private universities and private hospitals where that's the best thing to do. In other areas, we're working closely with the VA, so we have joint facilities. Still, we have to have a core called the MTFs, the military hospitals or military treatment facilities, where people train together and so that they can deploy together. This is critical for the efforts we're engaged in overseas, whether it's the wars in Iraq and Afghanistan, caring for our wounded, whether it's the best preventive, getting them in the best shape, to deploy, and whether it's teaching the Iraqis and the Afghans to take care of their own people medically. All these are things that we train to do together, and the health of the MTFs is critical. So thank you for supporting them. It's very heartening for us to have this opportunity to talk to you about the military treatment facilities, and I think next is Schoomaker, and I think then we'll have some questions at the end. But thank you again on behalf of my colleagues in the Department of Defense for this opportunity.
Cheney, go ahead, sir.
Good afternoon, Chairman Ortiz, Chairwoman Davis, Congressman Wilson, and distinguished members of the subcommittees. I'm honored to appear today before you. I'm taking the place of my boss, that's Wayne Arney, the Deputy Undersecretary of Defense for Installations and Environment, who is today attending his son's change of command at NAS Lemoore. He's the outgoing Strike Fighter Weapons School CO. Absent a significant personal commitment like that.
Sir, if you can get a little closer to your mic, sir.
Absent
Thank
a
you.
significant personal commitment like that, he would be here. I'll keep my remarks brief, and I'd like to relate what we do in the installations community in the construction world compared to what we do, the other witnesses today, in the health affairs world, as well as BRAC. So let me begin. The installations and environment community, my world, has oversight responsibility for the department's installation portfolio. We're the advocates for ensuring our facilities compete effectively for the investment necessary to sustain, restore, and modernize them to ensure their continued operation in support of their mission occupants. As such, we support our colleagues in the medical community in their application of the resources supporting Defense Department's health program facilities. The Department places great emphasis on sustaining all of our facilities. Sustainment is the term we use to describe what's necessary to keep facilities in good working order and the preventative maintenance necessary to avoid the increased costs and mission impacts that result from premature deterioration. To this end, we use something called the facility sustainment model. It's a robust tool we've developed to parametrically estimate the funding required for this purpose, and it allows us to gauge our investment against the requirement. And that was a substantial and significant development for us over the last couple of years, because now we had a tool to better compete for the limited resources we have in the department. And particularly because sustainment has been traditionally underfunded in the department. And in the 09 President's budget, we were at 90% of the overall requirement, and health facilities were at 93% of the overall requirement. That's better than it used to be, but it's certainly not where it should be. And we're continuing to work to get it up, frankly, to 100%. Sustainment is only one piece of the equation. Facilities must also be modernized through the investment we make in their recapitalization. Modernization is driven by new standards, new technology, and changing missions. And as such, it's not easily modeled. However, the fact that the average age of our hospitals is less than other facilities indicates we recognize the relative importance of their modernization. But here, too, there's certainly more to do, and the witnesses at this table will provide details of the work we're doing in order to respond to medical care advances. Restoration is the final part of the equation. While in the past the department had focused on recapitalizing facilities on a yearly rate, essentially a ratio of the funding we were placing in the budget compared to the replacement value of all of our facilities, and our 67-year goal was something I think you've heard about in the past. We've recognized the limitations of this metric, particularly with regard to medical facilities, and are working on more comprehensive measures. To that end, we're using Q ratings now, much more so in the past, and that's Q1 through Q4, Q1 being the best, Q4 the lowest, and they're essentially the percentage of work orders to repair a building compared to the building's replacement cost. Medical facilities have a higher Q rating than the rest of the department, but they're not a good indicator of our medical facilities' health because, no pun intended, because medical facilities have a higher priority, as I just said, and they're subject to accreditation requirements. And the accreditation requirements drive us to more robust engineering assessments of the individual condition of the facilities in coming up with our estimates. So we're continuing to refine our approach, and right now that's the best means we have available to gauge what it is we're doing as far as investing in recap, sustainment, and restoration. There's one special area that I need to note, and that's BRAC. Particularly here in the National Capital Region and in San Antonio. Those are the two major BRAC areas. BRAC is a significant recapitalization engine for the department. BRAC is pouring a lot of money into our facilities across the board, but particularly in the medical community. Through BRAC, the department is realigning, rationalizing military health care, particularly in the NCR and in San Antonio, as I said. In the NCR, we have avoided recapitalizing the aged Walter Reed facility so that we can instead focus our resources more effectively by realigning functions into the new Walter Reed National Military Medical Center. We're also building a new facility at Fort Belvoir that will address the significant demographic shift in patient population that has occurred in this area. In San Antonio, we are consolidating inpatient services into a recapitalized Brooke Army Medical Center and converting the aging Wilford Hall to an ambulatory care center. These two initiatives have produced investments in medical care in the NCR and San Antonio of $2 billion and $900 million respectively. These two areas, coupled with lesser BRAC initiatives, represent a substantial recapitalization effort. In closing, I want to thank these subcommittees for this opportunity. The Department's medical construction program has made great progress, but certainly more work remains, as you will hear from the other witnesses. We also recognize and appreciate the great support you have demonstrated for all of our efforts, and thank you. That's it.
Thank you, sir. General Roudebush, go ahead, sir.
Thank you, sir. Chairman Ortiz, Chairwoman Davis, Ranking Member Wilson, it truly is a pleasure to be here today to review our MILCON activities with you, to hear your thoughts and to provide ours. We believe this is a very, very useful and necessary opportunity. Thank you. First, let me express our gratitude for the overwhelming support that Congress and you in particular have provided to address the critical needs of our medical facilities. Your efforts will greatly assist us in building and sustaining the state-of-the-art medical facilities that we require now and for the future. This is especially important in the Air Force, as much of our medical infrastructure was built in the 15 years following the establishment of the Air Force in 1947. The shortage of MILCON funds in the past several years has forced us to pursue ever-increasing O&M repairs on buildings well past their useful life. While we've been successful in implementing stopgap measures in this manner, we cannot sustain an adequate baseline of maintenance and repair. To properly characterize and prioritize our Air Force MILCON requirements, our Air Force Health Facilities Division aggressively engages with each medical facility leadership to identify those modernization requirements that are most pressing. Our prioritization of these requirements is then aligned to an Air Force-wide perspective. For requirements that drive a MILCON solution, we now prepare a capital investment proposal and submit it to the TRICARE management activity to be scored in the Military Health Service Capital Investment Decision Model, the CITM process, which you've heard a bit about this afternoon. This CITM process was successfully applied in 2008 to determine the Department of Defense fiscal year 2010-2011 military MILCON priorities, and I can report to you that the Air Force's most pressing medical projects were appropriately prioritized within this process. As a result, we're beginning to turn the corner on our MILCON shortfalls. As we work to recapitalize our infrastructure in both the MILCON and O&M arenas, it's important to note that green design initiatives and energy conservation continue to be high priorities in the Air Force Medical Service. We're already incorporating nationally recognized benchmark processes to design and construct buildings with sustainable design elements such as increased natural daylighting, recycled or recyclable materials, and optimized energy performance. We've established a rigorous system to capture and compare energy consumption data from all of our major facilities using the Energy Star measurement tool, and this system is already up and running at the majority of our medical facilities. And finally, we recognize that caring for our airmen, soldiers, sailors, Marines, and their families in safe and well-maintained medical facilities is both our duty and a national priority. I assure you that the Air Force is meeting these expectations. All 74 Air Force medical facilities undergo regular and thorough inspections, both scheduled and unannounced, by two national accreditation organizations, the Joint Commission and the Accreditation Association for Ambulatory Health. All Air Force medical facilities have passed inspection and are fully accredited. Again, we thank you and look forward to your continued strong support in this critically important task, and I look forward to your questions. Thank you.
Thank you, sir. Admiral Robinson.
Good afternoon, Chairman Ortiz, Chairwoman Davis, Ranking Member Wilson, distinguished members of the committee. Thank you very much for the opportunity to testify before you today on the prioritization of military construction of medical facilities. Your unwavering support of our service member, especially those who have been wounded, is deeply appreciated. Navy medicine continues making significant strides in enhancing both living quarters and medical treatment facilities for our sailors and Marines. The Military Health System's Capital Investment Decision Model was implemented in May 2008 and was used in the programming and budgeting of military construction projects slated for construction beginning with fiscal year 2010. This new system serves all the services by carefully evaluating proposed medical MILCON projects through a rigorous capital investment prioritization method across the entire enterprise. In addition, the new methodology allows more costly projects to receive the funding they need by harnessing the global, enterprise-wide perspective to effectively prioritize scarce resources. Another positive aspect of the SITM prioritization process is the inclusive representation of those who care for our warfighters as members of the Military Health System's Capital Investment Review Board. Clinicians, health system managers, resource managers, and healthcare facility experts from the services and from TMA are all voting members of the Capital Investment Review Board. They represent their services or TMA and play pivotal roles in creating an enterprise-wide assessment of projects needed. As Navy Surgeon General, I, as well as my Army and Air Force colleagues, can engage the capital investment decision model process to clearly articulate our views and priorities to all the members of the SERB for consideration and deliberation. The SITM and the SERB delivered the Integrated Military Health System Priority List of projects for the programming period from 2010 through 2015. The services Surgeon Generals and the TRICARE management activity came to a joint agreement on the top priority construction project, and it is the Naval Hospital Guam replacement. This antiquated facility was built in 1954, and has survived 55 years in tropical climates. The new prioritization system allows us to maximize our limited project planning money by focusing on projects that are considered by all to be a major priority and the best and most efficient use of limited resources. Distinguished members of the Readiness and Military Personnel Subcommittees, thank you again for the opportunity to testify before you today on the positive results Navy medicine has experienced from the new medical MILCON prioritization process. I believe that the Military Health System's SITM and associated SERB, as implemented to date, offers the military health system enterprise the best overall means to properly prioritize military medical projects. In addition, this new process ensures projects of the highest relative merit are consistently programmed, budgeted, and executed first in a coherent fashion, while still ensuring the focus of the entire MILCON evaluation process remains where it should always be, namely the healthcare needs of our sailors, our Marines, and their families as our #1 priority. Thank you very much.
General Schoomaker.
Chairman Ortiz, Chairwoman Davis, Representative Forbes, and Representative Wilson, distinguished members of the Readiness and Military Personnel Subcommittees, thank you for inviting me and my colleagues here to discuss this really important subject today of our medical infrastructure. Before I go on, I'd just like to take a moment to introduce my battle buddy, my Command Sergeant Major Althea Dixon. Although we're talking about buildings, brick and mortar today, I think we can all agree that the centerpiece of our formation are our people. And the Army has declared this year the year of the non-commissioned officer, the NCO, and probably nobody better symbolizes the NCOs of our Army than my senior medic here to my left, who's kept me honest and on track for a number of years now. The condition of our military medical facilities speaks volumes to our staff and our beneficiaries about how much the nation values their service and their well-being. In fact, I use these exact words when I turn the soil with my colleagues at the new hospital at Fort Belvoir. Most tangible evidence of the nation's investment in the health and well-being of our people are the facilities that we build for them. As I testified before the two Defense Appropriations Subcommittees last year, medical facility infrastructure was and remains to this day one of my top concerns. On behalf of the 130,000 team members that comprise the Army Medical Department throughout the world and our 3.5 million beneficiaries whom we serve within Army medicine, I really want to thank you all here and the Congress as a whole for listening to our concerns about military medical infrastructure and taking some significant action to improve our facilities. With your help, I think we've made some real progress in the last year. Funding provided for military hospitals in the FY08 supplemental bill and what we hope to have in the American Recovery and Reinvestment Act of 2009 will positively impact the quality of life of thousands of service members, family members, retirees, as we build new world-class facilities in places like Fort Benning, Georgia, Fort Riley, Kansas, and San Antonio, Texas. And I think we can all sit here and talk to you about the abysmal state of some of our facilities, but I don't want to get in a contest with my colleagues here. We all are working very, very hard to raise the quality of our facilities, and while doing that, using our SRM dollars to maintain the safety and the reliability of even these aging facilities. Modern new facilities not only stimulate the local economy, they energize the hospital staff who work in these new spaces, and they comfort the military beneficiaries who seek care in them. They become healing environments for our patients, and they inspire confidence in their families. As a child who was raised in and around Army hospitals and clinics myself, a husband and a parent of an Army family who's received care in these same and some newer medical treatment facilities, and as an Army physician who served and commanded a variety of hospitals, I can tell you I've witnessed firsthand the impact and improvements of our infrastructure made. I was one of the first chiefs of medicine at the new hospital that we opened in 1992 in Madigan Army Medical Center, Fort Lewis, Washington, and I helped lead the transition from that. The impact of that new facility was really nothing short of startling. The old hospital, although it was beloved for this sprawling one-story cantonment facility, covered many, many acres and miles of corridors, it was really a challenge for all of those who attended to the sick and for our patients as well. And the new hospital, when we built it, was sited such that it either looked out over Mount Rainier or the Olympic Peninsula, and it had an instantaneous effect on patients. It created a sense of patient and family centered care and patient-friendly waiting areas in clinic spaces. The impact of all that light and fresh air and even the selection of photographs, of artistic photographs that we had, really was instantaneous on patients. I saw it in my patients' faces, I heard it in the voices of their families, and I witnessed it in the renewed energy of our staff. We really had little difficulty following opening that building, attracting trainees into my department, and we used it as a major recruiting tool for Army medicine and continue to this day. The three services in the TRICARE Management Agency have worked hard to develop an objective process for prioritizing medical MILCON requirements through this capital investment decision model. I won't go into it in length. You've heard about it from my colleagues. But its criteria focus on supporting all of our needs simultaneously and also targets the heart of healthcare, looking at the need for functional modernization and customer and patient-centered care, our productivity, and how we use our space. In 2008, we in the Army participated in the development of the first version of this prioritization model, and I believe it really is a step in the right direction, but it requires continuous development and refinement. The Army is challenged, as all of my colleagues have described, with aging facility infrastructure, with growing workload, and caring for a large portion of our D&D beneficiaries. We maintain about 40% of the total inventory of medical buildings, 1,800 in total, of which 386 are direct health care facilities with a replacement value of about $9 billion. Our critical priorities right now for hospital replacement are at Fort Hood, Texas, and Fort Bliss, Texas, Landstuhl, Germany, Fort Irwin, California, and Fort Knox, Kentucky. We've identified requirements for another 12 hospital expansions, 25 health and dental clinic replacements or expansions, and 16 force projection projects. These are research facilities and blood centers and preventive medicine clinics and training facilities. As Landstuhl, our regional medical center, which many of you, if not all of you, have gone through and probably been impressed by its critical role in evacuation of casualties back home, approaches its 56-year anniversary. We see this as a critical need for our replacement. Launch Stool is an enduring part of our evacuation and treatment plan for wounded, ill, and injured soldiers throughout the world, and I would ask you to consider it as a significant infrastructure need. We also continue construction on a state-of-the-art replacement facility for the United States Army Medical Research Institute for Infectious Diseases, the HOT Zone, up in Fort Detrick, Maryland. This is part of a national interagency biodefense campus that's partnered with the the National Institute for Allergy and Infectious Diseases, the Centers for Disease Control and Preventive Medicine, the Department of Homeland Security, and the United States Department of Agriculture. It's a realization of a post-9/11 vision that brings vastly different and new government agencies together for a common cause. Providing appropriate facilities for this and other areas of medical research are just as important as our hospitals and contribute greatly to the readiness of our soldiers and the defense of our country. I respectfully request that we continue the support of the DoD medical construction requirements that deliver treatment and research facilities that are the pride of this department. In closing, I want to thank you on the Readiness Subcommittee for your interest in this issue, and the Military Personnel Subcommittee for your vigorous and enduring support of the Defense Health Program and of Army medicine. I greatly value the insights that the Armed Services Committee and look forward to working with you and your staffs over the next year. Thank you for holding this hearing, and thank you for your continued support of the Army Medical Department for our warriors and our families.
General, thank you so much, and we want to thank all the witnesses and all the staff for the fine work that you have done and will continue to do for delivering the best that you can medically to our soldiers. Mr. Potochney, let me ask you a question. On Monday, we had the opportunity to visit Bethesda and see the magnificent care that is being provided to the wounded warriors. And frankly, I was very, very impressed. So were the members who were with us on this tour. We were also briefed on the magnitude of the BRAC effort associated with the realignment of Walter Reed. We were told that the moves associated with this realignment would occur in August 2011, 1 month before the statutory deadline. Maintaining the quality of care that exists today is extremely important. Now, how important is your estimation date in meeting the September 2011 deadline, and what steps would be put in? And you know, I've been here several years in the Congress. I'm just wondering, how did we get to the 2011 date? Was it you in the medical field? Was it DOD? How did we get to that date, 2011? Was it the BRAC Commission? Maybe that's the first question that we would like to know.
I'll take the first shot at it if I could, sir. The department is implementing the BRAC Commission recommendation on the schedule that it established. During a year and a half or so ago, excuse me, the department also decided to enhance and accelerate, but mostly enhance some of the construction and the facilities at Bethesda, which has stretched out some of the construction. So the department itself, and we can't blame it on the commission, has decided upon a construction schedule, a facilitization schedule that brings us bumping up against the end of the statutory 6-year period, which is September 2011. That's the answer to your first question, sir, I believe.
Yes, sir.
We did it.
The thing is this, you know, I know that you're going to receive the hospital when the construction is finished. But then you're going to have to buy a lot of equipment, and a lot of equipment will be there. There will be testing on the equipment. Is it realistic to say that by September 11, not only will the hospital be finished, but that you will also have all the equipment to start functioning as a first-class hospital?
Yes, sir. I wouldn't argue that it's an aggressive schedule and it's a challenge. Admiral Madison, who you all met on Monday, is confident, we've spoken at length about this, that while it is aggressive and it's a challenge, he can do it. And he wants to do it that way. He will have equipment delivered before then, and the hospital will be run through its paces. But the actual transition of patients over into the new facility will happen in a compressed period of time within a statutory deadline. Why is it a compressed period of time? Admiral Madison feels strongly, based on his own opinion and the research that he's done, is that doing it on a compressed period of time is the best for the patients. to get it, in other words, if you permit me, it's do it in a concentrated effort, get it over with quick so you're back up and running as fast as you can. And that's his position.
So you feel comfortable that by the date of September 2011, you'll be running smoothly and ready to go?
Yes, sir, but I can't say that we're not wary and exercising a fair amount of vigilance to make sure that it remains on track.
We want to be sure that this does not degrade the quality of care.
Yes,
This is why, earlier I said what we would like to do, and I don't want you to feel pressure from me or from some of the members here. We want you to do it right.
Yes, sir, so do we.
And this is more important than anything of meeting a deadline. But it will not degrade the quality of care that you're going to.
Yes, sir, we've signed up to that, and right now we're on a schedule that we can meet. If something changes, I'm sure you will be seeing that as quickly as we are.
And just like I stated earlier, we walk into the hospital, and we were so impressed. For once, I saw something that I said, my God, they have it right. The way you're giving treatment to the warriors. And I don't want to take too much time because we've got a lot of members who have a lot of questions, but I'd like to turn it over now for questions to my good friend, the chairperson of the Personnel Committee, Ms. Davis.
Thank you, Mr. Chairman, and again, thank you, all of you, for being here and for your service to our country. General Schoomaker, I wanted to ask you about any limitations that the Army may have providing care as a consequence of an undersized or antiquated military treatment facility. And the issue really is that if we have a MTF commander who feels a need to send a beneficiary downtown, for example, because they can't be treated in the facility for whatever reason that might be, perhaps it's because they would get treatment sooner if they did that, if they went to another facility. Does the MTF then not get credit for that workload? And can that come back at some future time to suggest that the workload isn't as great as they might be representing? How might it affect future budgets down the line? How is that decision-making around that impact future budgets or even the workload generally?
Well, ma'am, I think that is an excellent question. I would say in the past we would have been much more focused on what I call how many widgets of healthcare we build and deliver in a sort of a simple productivity model. But I think that led to some bad clinical and business practices, not the least of which was an impetus to hospitalize people when perhaps management in an ambulatory setting is much more important. What we in Army medicine are doing, and I'm pleased to say that we across the MHS are doing increasingly, is shifting to a model that really looks at the total outcome of care and asks the question, what's best for a patient? And what does the patient need for that particular condition? And or what can we do to prevent the beneficiary from being a patient at all by doing preventive measures? Mm-hmm. And so we're shifting a lot of our resources and our revenue generation, if you will, toward prevention and toward outcomes. I mean, I frankly spend more time with my commanders, regional commanders, and through them my medical treatment facility commanders, focusing on, are you practicing good evidence-based medicine? Are you practicing good preventive medicine? And not whether they're shifting work downtown or keeping it within the hospital.
Yeah. Is there a lot of care that's being shifted? How would you characterize the kind of care that needs to be diverted from a major facility?
Well, we still perform the vast majority of the care, both inpatient and ambulatory care, within the direct care system. We are sending more cases of care of patients that are enrolled in our facilities downtown as we're taking care of more wounded, ill, and injured soldiers, as we're more intensively placed in there, as we deploy our own caregivers to theaters of operation and don't get prompt replacement because of hiring lags and the like. But those are the dynamics that generally, and then there are highly specialized care that may be given, say, in South Carolina at Columbia, we won't necessarily have highly specialized cancer care or something, and so we lean upon, or we depend upon, our colleagues in the VA and Columbia or in the private sector to deliver that care. That's really the kind of the rubber band between the direct care system, as we call it in our uniform services, and our TRICARE managed care support contractors.
Mm-hmm. Can you characterize, I know in certain areas it's going to be more than others, but is there a way of saying that, you know, that a third of the care, quarter of the care?
No, ma'am, I would say, I mean, my ballpark would be across across Army medicine. I would estimate that probably no more than about 20% of the care that we've enrolled in our hospitals is going downtown, and that shift to downtown for specialty care, or when families are displaced by soldiers that are growing in the community, that's occurring in a minority of the cases.
Mm-hmm.
Does that answer the question, ma'am?
Yeah, I think so. I think part of the concern is, I think initially that there is, is there a reluctance to even send a beneficiary for care someplace else?
Yes, ma'am. I think there's very much a reluctance, in part because when we used the network of care, if I've enrolled, we use very, very strict enrollment models to ensure that our hospitals do not over-enroll to their capacity to deliver primary care, which is the principal driver for getting subspecialty care. There's a reluctance to send our enrollees into the network for a number of reasons. Number one, it disrupts continuity of care. Number two, we don't have the information systems that give us ready access to what's done downtown, and it may take us a month or longer sometimes to get information back about the patient that has gone downtown. So is there a reluctance? There is, but I've given direct and specific orders to all of my subordinate commanders that they will not compromise access standards under the TRICARE published access standards in order to hang on to a patient that should go downtown.
Mm-hmm. All right, thank you. I appreciate that. And kind of quickly, I think it's been mentioned, Dr. Casscells mentioned the fact that there are about 59 hospitals in the military health system. And how many of those, Dr. Schoomaker, are Army, of those 59?
I have a total of how many? 36? 35 hospitals in the Army.
When you look at the system that's being used now in terms of the prioritization, and we obviously have a representation here in Congress. No matter how many issues we have one vote on a particular issue. Does that in any way compromise the outcome, whether or not you could move and each have a single vote as opposed to a collective vote on those issues, or even a proportional vote?
Well, I have suggested that I get the entire vote, but that didn't go over very well with my colleagues. Ma'am, I think this is one of the really tough things about running the sit-in process, is trying to decide the strategic value of various installations and various facilities, and ensuring that as a department that we don't leave someone behind simply because they don't have a constituency. You heard my comments about Landstuhl. I think you heard Admiral Robinson's comments about Guam. It's very hard to get a constituency for some of our OCONUS facilities, even though they may have strategic value to the force. So I look at the sit-in process. I characterize it the way we look at personnel sometimes. We're not happy until everybody is equally unhappy.
Thank you. Thank you, Mr. Chairman.
Mr. Wilson.
Thank you, Chairman Ortiz. And I want to join you and my colleagues for the opportunity that we had to meet with Admiral Madison and his staff. It was really exciting to me, just as it was for you, to see the dedicated staff. They were so interested in the wounded warriors, each one. They were so proud of the progress that they were making. It just made you feel so good to see the extraordinary planning and thoughtfulness put into the individual care given to each one of these young people who make such a difference for our country. Additionally, for each of the Surgeon Generals, I think you should be, I want to thank you for making military medicine some of the most advanced in the world. It's looked to around the world as leading the efforts in terms of prosthetics, in terms of trauma care, in terms of preventive virtual medicine, on and on. I wish the American people knew of how extraordinary military medicine is, and the challenge that you have. And for each of the Surgeon Generals, and you've touched on this, but all of you have hospitals and military facilities that would be considered old by any standard. How do each of you prioritize the facilities that you submit to the Military Health System MILCON prioritization process? And what are your top priorities for medical MILCON for the next 5 years? And Admiral, I had the opportunity to fly over. I didn't actually visit the Naval Hospital last month at Guam, but I'm very happy as the Marines are being relocated there to hear that is proceeding.
Yes, sir. Thank you very much for the opportunity. Guam is proceeding. I think that Guam represents the overseas OCONUS facility that doesn't necessarily have the constituency, does not necessarily have the TRICARE network in downtown that can take care. Not suggesting a network doesn't exist, but it doesn't have the robust network that a CONUS facility may have. So the point is that the educational development instructional programs, the exceptional family member programs, the programs that are related to specialty care with the network, all of those programs may be at either lesser condition or may not exist OCONUS, which then makes those facilities a top priority from a Navy medicine perspective, because I have to make sure that the men and women and families there are cared for appropriately in that particular geographic location. I also think, related to the question of network care and going downtown, network care and access standards are always going to drive how we do business, and they should. At the same time, the reasons that patients often don't want to go downtown is that, or we send them downtown, is that they don't want to go down. They would rather stay with us. With that said, we will never degrade care or get into a quality issue with the patient related to an access standard. I would suggest that if we could re-look at network and how we run military networks within a geographic area and give more responsibility to local commanders with the network, that there could be a more seamless and effective method of how we would actually run our patients and the network, both from the direct and the purchase care side, so that we could have a better and a much easier system of care, and I think the continuity and the quality would follow.
Mr. Wilson, I appreciate your question because it helps me put things in context for the committee. As I mentioned, a significant amount of our medical facilities were built within 15 years after the Air Force was established. The Air Force is positioned across the United States, generally in small communities, and many of our medical facilities were in fact small hospitals. But we very appropriately followed the U.S. medical model, and we closed those small hospitals in favor of ambulatory clinics because they didn't have the critical mass, they were costly, and frankly they were not safe. They didn't have the caseload and complexity to maintain the currency that the staff would require. So we followed that model, and we have a significant number of ambulatory facilities which really are in old inpatient chassis which have been modified over the years. So those do in fact create a concern. Now I will tell you that we do have 15 hospitals, and we have leveraged our O&M dollars as well as our MILCON to maintain those platforms, although several of those come up on the priority list that you asked about. And two primary ones would be the Wilford Hall Medical Center, which under BRAC becomes a large ambulatory surgical center, as does the Andrews Hospital become an ambulatory surgical center. So from an aging infrastructure standpoint, they need to be replaced. And from an alignment with BRAC to assure that they are viable parts of that BRAC outcome, they need to be replaced. So that is in fact driving our prioritization as we work through this process, along with other facilities in the 2010-2011 window. But that is where we find ourselves with aging facilities, but also the need to align appropriately with other activities with our sister services in BRAC.
Sir, we'd use a model of prioritization that's based upon three principal factors: what the current condition of the hospital or the facility is, and how much it's going to cost to repair that. Obviously, the more that's going wrong within a facility that we can't get back to a safe and high standard, then the more impetus to replace it. We look at the population that's supported by that facility and what its capacity is to take care of that population, to include the population that's moving. I think you all are aware that the Army right now is going through four simultaneous kind of word salads: global defense posture realignment, grow the force or grow the Army, Army modularity, and base realignment and closure. GDPR, GTA, AMF, and BRAC are moving about 250,000 people right now, the largest movement of soldiers and their families across communities in a generation. And so we're also looking at projected populations served by those facilities. Last thing I'll make a comment about is General Roudebush says, although we tend to be sort of hospital-centric in our thinking, we're comprehensive in building facilities that attend to the health requirements and dental requirements and preventive medicine requirements and veterinary public health requirements of that community, and I don't think we want to lose track of that.
Thank you very much. And in the interest of time, I'll submit further questions because we have votes.
We will now allow Mr. Reyes to ask a question because he'll take 45 minutes before we come back. And you are very important individuals. We don't want to keep you here. So we will see with Mr. Reyes. And you have a question?
Yes, Mr. Chairman. Thank you. Secretary Casscells, the Navy Surgeon General stated in his opening statement that the replacement of the Naval Hospital at Guam is the top military construction priority identified by the capital investment model. Can you share that report with our committee? And also, can you tell us how new missions like expansion or grow the Army and return of overseas troops are accounted for in that model?
I need your help. Mr. Reyes, I'll be able to share the detailed analyses that Admiral Robinson mentioned in just a few weeks' time. I can say as a general matter that Grow the Force and Grow the Army initiatives are generally paid for by the Army, and not by the Defense Health Program. The Defense Health Program pays for the bulk of the replacement and maintenance of these facilities, but those two initiatives are really line initiatives. We work closely with the services. So, for example, Bliss, which Fort Bliss, as you know, and Fort Sam Houston, which are both impacted by multiple Army initiatives, transformation, Grow the Force, and so forth. So that this is all, all the cards are on the table when we make when the military health system makes its decision. As you know, it's a process that the surgeons and I jointly devised, and we jointly participate in with our staffs, equal votes. And I must say, these are some tough calls, but we've ended up in unison on these, and so far. What we hope to be able to tell you in a few weeks is the detailed results of that as part of the President's budget. And hopefully a year from now, those who will still be with you, like General Schoomaker, will be able to tell you whether the capital investment decision model is in fact the plus that we think it is right now. Right now, it's promoted communication and transparency and unity, so far it looks good.
Well, it doesn't look too good from where I'm sitting, because Fort Bliss is about to quadruple in size, in troop size. We're going to have 100 to 125,000 people that are going to depend on the facility there, which was designed to accommodate about 12,000 troops. So my concern, and this is why I asked the question, my concern is being up there as the next priority, because if we're not, then we're not going to have a medical facility ready and prepared for all the troops that get assigned to Fort Bliss. I had a discussion with General Schoomaker earlier on that, and he's promised to get back to me on several questions that I had, but there's got to be a way to factor into your formula, into your decision, facilities like mine that don't have adequate medical facilities and are going to grow the way they are. So I hope you take that into account, and I'm going to follow up with both you and General Schoomaker in the next
Yes, sir.
week or
May I
so.
just follow on and say that my medical privileges as an Army Reserve doctor are at William Beaumont, and I know it well. I know its shortfalls, and that was where my pre- and post-deployment experience were. I've been a patient there, and I absolutely agree with you. I can only say that our understanding with the Army now is that they've got that covered, but it is our obligation collectively to make sure that that comes true.
Very good. Thank you, and thank you, Mr. Chairman.
Thank you so much. I would like now to allow members, I'm sorry, Mr. Klein, you have a question?
I do, Mr. Chairman. Thank you very much, and I'll just get the answer for the record. Once I ask for a nod, General Schoomaker, you mentioned there are 3 services, and of course there are, that provide medical services, but there's a 4th service that uses those medical services, generally in the responsibility of the Admiral. But I know from my past experience there are a lot of Marines who live down at Quantico who go to Fort Belvoir because there's no naval hospital at Quantico. And we're building a new facility there as we're bracking Walter Reed and so forth. And I just want to be reassured that CITM and the system is accounting for that 4th service. And there will not be time for an answer because we've got to vote. But if the system accounts for that, then we're on track. But it's an Army hospital. It's got a lot of Marines and other service, but particularly because there's a very large Marine contingent at Quantico. If somebody will just tell me that the system has accounted for that.
Absolutely, absolutely.
It not only does because Guam is the #1 priority, partly because of the Marine growth that's...
No, I understand that, but that's because there are Marines living there and you know, at Guam. But this is a little bit different situation. We got to vote. I'm going to yield back, but I would like to follow up with your staffs on how that works. Thank you.
Yes, sir.
Thank you so much. What I would like to do is to allow other members who couldn't be here to submit questions for the record. And I know that there's many questions. I wonder if my good friend, the chairwoman of the personnel, do you have any statement? Thank you so much, and you were outstanding witnesses today. Hearing stands adjourned.